Everything's good. And you? From north side of the country, from the south side?
And Brazil is a giant country, but Maria, I know Maria Fernanda in person, and she's fantastic.
This presentation has not a picture of you, just to let you know. The
Okay,
other one.
now I am a little. At least when you are going to choose a picture of mine, choose a nice one with a big fish or something like this.
No, it's okay. I just want to connect this one. This one, as I just want to be a little dramatic in this case presentation, just for your information. That's why. Let me open. Onde é que tá agora? And then we can start. If we can, por que não abre? Ah, internet.
Dr. Detanico, I have the preliminary presentation you sent me. I can run it from here. I know there were some slides, there were some blank slides, but I do
Yes,
have your
no.
preliminary presentation.
Let me see why it's connected, and I don't know why this is not. Let me try this one. Presentation. I changed it a little bit, that's why I want. Ai, que meu Deus, que me dá nervoso.
But Dr. Tanaka, if you email your presentation to Kevin, he'll show it for you, and then you can read it. You can.
Perfect. I can do this too. This one, it's the. Let me see. Kevin. I think it's more a connection issue here. It is slowly, very slowly. I'm trying another one. This one. Let me try this one again. What I can try is being two computers. I'm gonna be a little bit crazy, but it's okay. Kevin, anyway, I'm sending to you this one.
Okay.
This is like the most impressive thing, intercontinental data transfer until last week when they're talking from, 200,000 miles away, having a conversation between the moon and here. That's until a few days ago, this was very impressive.
Yeah, and now Artemis 2 has launched, and the next step for us with this Telegram round is to have someone in the moon discussing the trauma cases with us here.
Yeah, the first trauma case on the moon, that'll be in a couple of years.
It might be sooner.
Yeah, I think.
Yeah, there you go. Oh, that's kind of our humor. And it's going to be in a couple of hours. They're going to be around the backside. And in 2011, I was in Antarctica, and I worked with that woman, Christina Cook. She and I worked together on the station. She was a technical support staff. I am so impressed and envious that she's up there now, 15 years later. My goodness, going around the moon. She pressed the button to make the rocket as it was about to crash into Earth turn around and zip out toward the moon the other day.
She's over the moon for you.
Oh my God! I touched base with her when I was in Kwajalein. Her husband is in the Army Corps of Engineers, so she came to visit. And I learned back then from the base commander who was up on the space station with her, a physician, that she was chosen for this mission a year and a half ago. And here it is. It's just, oh my goodness. Jeez, spectacular.
Put your name in. Put your name in the
I
pot.
Yeah,
think
that's what I said I was going to do. If they take an old guy, I'd spend the rest of my retirement years preparing. I'll be the first old guy on the moon.
Maria,
You're
I
not
think
old,
I could
Dr.
open.
Untrack.
Huh?
Dr. Detanico, I haven't received anything yet.
Yeah, no, but I could. I have not now. I could not send you, but it's opening. So
Okay.
There
okay.
we
if
go.
we
Oh,
can
yeah,
start.
yeah. This is Dr. Adenauer, that's you, right?
No, that's not me, my friend.
Yeah, it looks just like
Mr.
you.
Beans.
Maria Fernanda
Mr.
is very
Mr.
Bean.
funny
Bean.
with this
Just,
picture stuff, but this
just,
time it's not me.
just like you after a night on call, up in the OR all night.
So
That's a great slide.
let's. So this one, and as I told you, I would like to be a little dramatic in this case. It was quite simple, I can tell you, but there is small details that I would like, because was my face maybe during all the time with this patient. So that's why I put, where do we cut when we decide like it's done, it's over, we cannot more do a no operatory treatment, we need to do something. It's my point with this patient, especially this one. I have all the CTs, so we can discuss. I don't know if you want to give some presentation at an hour. So,
And also, can you put your presentation, your slide deck in presentation mode, please, Doctor?
oh, this one, I think now it's, why is not? No, it's stopped.
There
There.
you go.
There,
Yeah.
Got
here
it.
we go. Yeah.
Yes. Yeah, Doctor, if you want to go ahead and please go ahead and introduce Dr. Detanico, and we can go ahead and get started. Thank you.
Dr. Detanico is a trauma surgeon from Porto Alegre, a very beautiful city in the south of Brazil. She's also a member of the SBITE, the Brazilian Trauma Society, and a friend of mine. Unfortunately, I didn't receive her official CV for make a professional presentation, but well, Maria, go ahead, please.
So I will start with this patient. So, porque ela não foi. Por que não vai? Foi. So this patient, it's a male. Oh, I didn't put all the rest. It's a male patient from 22 years. Fall from height, more or less 3 meters. The arrival at the hospital was about 1:50 p.m. He was referring pain at the wrist, the right wrist, and right ribs. And the first exam was done, but for the doctors from the emergency room, it was pretty much everything okay. Stable, no other issues and no other complaints, just the pain at the right wrist and the forearms and ribs.
Maria Fernanda, are you still there?
I think she's frozen.
Froze. I will call her because I don't know if she realizes it's not working.
Oh, she's back.
So, Maria Fernanda, you were frozen. We stopped in the second slide. You need to open your mic. The microphone is closed.
So, okay now?
Okay.
Perfect. So this is what happened. So it was a medium trauma
We're
with
not
a
seeing your
young
presentation,
man.
doctor.
Let me do it again. Just
Okay,
a
we got
moment.
it. It was a 22-year-old male that
Yeah,
fell from about 3 meters high,
yeah,
complaining about right wrist and right ribs.
yep. Deixa eu ver se é
And
isso
then
aqui. Cadê o...
we lost you.
I have your
Nossa,
presentation that I just got your email. Do you want me to show it?
I don't know what is happening that this one should be here. Yes, something.
Would you like me to share my screen and show it and you can just talk
Oh,
about it?
yeah, perfect. Thank you. I don't know what happened here, to be honest. Here, probably. So I need to, where am I?
Can you see my screen?
Let me see,
Yes.
come back.
Yes.
Okay.
We need to move
I'm
on to
not
second
seeing.
slide.
Yep, perfect. Now I could
There.
see you. And so he was admitted, yes, for the orthopedic ward with this broken wrist, with broken radial, distal radial. They tried to put on place at the first moment, was not able. So that's why they plan to admit him and do a surgery. So this is what happened. Next, no other specialty was called at the first moment. So please, the next one. So at 11 p.m., more or less, 23 hours here in Brazil, they called the clinical, the medical doctor inside the hospital, because he was hypotensive. The heart rate was not elevated, and he was in abdominal pain and nausea. Maybe a history of a convulsion, but it was not confirmed. It was a little bit confusion. And what this doctor did was IV fluids, 1 liter of Hinger, a simple abdomen CT, and the surgical evaluation. This is what he done at the first moment.
Okay, Maria Fernanda, let's stop for a few minutes here and let's discuss some things. For example, I would like to ask Dr. Utrich if he would have done something different in their first survey for this patient.
Yes, I think this is a problem that shows up still in some locations. Spent a couple of years in Western Africa and Guinea, and all the trauma was sent to the orthopedic surgeons. Now, often they tended to do a reasonable workup, including not just the bones, but the CNS and the abdomen, whatever. But it's not ideal, and I think in this case, the patient came in, and I'm guessing that he walked in or had somebody drive him in. He didn't come by ambulance, and I don't know how long after the fall he presented, but I'm guessing he didn't come by ambulance. Was seen by the ER doctor, and he just treated it like a simple fall without doing a full evaluation. But probably, if there are any questions, it would have been better to call a general surgeon or a trauma surgeon or do the evaluation himself according to ATLS. And then, don't just jump to the obvious injury, but if it's based on the history, fall from 3 meters, work him up for this potential problem, including, an initial hematocrit, and then after he gets a little bit of fluid, repeat that hematocrit, see if it drops, which it probably would have, and then he might have done the CT earlier and called you earlier. So, of course, we all would have done something different. But this is the way it used to be done and is still done in some parts of the world or by some doctors simply because it's a matter of education or discussing the current protocol. So this is a good learning opportunity for the doctors involved initially.
Based on Maria Fernanda's first
Mm.
slide, we know for sure something very interesting with this liver is going to happen. But I keep thinking, if a guy falls from 3 meters and arrives complaining on the right with sorrow in the right ribs, where is the chest X-ray for this guy, for example? Simple
It was no, it was done. It was normal. So that's why I didn't.
Because
That's why
I only
it
got
was
the film for the wrist. I didn't realize.
no. Okay.
Okay.
There was
And
a thorax, and also there was the specific one for the thorax, the chest, and the bones, also the ribs. But it was okay.
So,
But he
so
was complaining of that, especially he was complaining of pain in the. He was talking about the ribs because it's what the patient said. But we need to understand that it's probably the transition, the thoracoabdominal, the right thoracoabdominal transition. But there is no broken bone at this time, and this is something that I think that they didn't really taken a real importance of this pain, because there is no broken bone, so nothing, just contusion, keep moving, no need for another, at that first moment, no need for another exam like a CT or something like this.
okay, and colleagues are interacting with the chat, sending messages. So Dr. Calderon asked if a fast examination was performed.
It was not on the chart of the patient. I don't know if it was done, but I presume that not, because it was not written.
Okay, and Dr. Epstein asked if liver enzymes were requested.
Not at the first moment also.
Okay, so let's proceed a little bit with the case. What happened next?
So this is what happened, just a little bit. As I told you, like both surgeons were in the OT, so it took a little bit for us to do the evaluation, but the patient was, the doctor, I think it's another problem. They just asked a CT with no contrast, no IV contrast, until it was a little bit difficult for us to, because somebody asked it, what's the grade? We cannot see at the first moment. So when we were called and we took place to see this patient, so he was like in abdominal pain or nausea and vomit. So we asked for a CT with contrast, and this was the first hemoglobin that when he was admitted, and now we have 3 points more or less fall from the hemoglobin. If you want, I have the first CT. If you want to see, I can share with you. Let me see.
Okay, I'll stop sharing then.
Here I am, because I have the both share screen. Let me see if I can. No, okay. No. I'm trying because this one is better in the system of the hospital. It's better than for me to put on my computer sometimes. Let me see. Can the host now? So share screen. Can you? It's not allowed for me to share my screen, Kevin. If you can.
Okay.
Well, it's not. Let me see again. Well,
Okay, I'm sharing my screen.
Yeah. It's not.
We have seen that screen. Kevin, can we advance?
Yeah. It's not.
Thank you.
Yeah.
Sure.
So what we did, so at this moment that we have a big, extensive grade 4, who asked at the beginning, grade 4 liver trauma, extensive subcapsular hematoma with compression of the right liver. And we are not so sure if there is active bleeding at this moment. So that's why we ask now angio CT. So, and what we started, let me see, it's opening? No. I don't know if it's, so we decided like nothing per autos. We trying to keep him inside the ward, not putting him in the ICU at the beginning, and like keeping monitoring him, but because we didn't have it. Can you come back one, please? The CT was really nice, if you could see. I don't know why I'm not allowing this. I'm not seeing any. Just this one? Yes. And I'm not allowed, I think, to share. But I'll try to do another thing. Maybe you can do this way. It's not gonna be perfect, but we can try always. So just to have an idea, we have the hematoma in this part also. I don't know. I don't know if you could see. No, no.
Maria Fernanda, unfortunately, it's okay. Now we have a chance.
Yeah.
It was too far.
Yeah, no, I'm just trying to. So this one. So we have this one in the right liver. We have this area here also in the posterior. Also, we have this one. This is the arterial phase. I'm gonna put the venous. So I'm gonna change for this one. Just gonna go down just to be fast. Just put a little bit more here. So we have this 22 years old patient with this huge, extensive subcapsular hematoma, and this one also with the liver in the middle. My point at this beginning was do not touch, do not cut, do not operate. Try to be conservative. Try to not operate. So at the first moment, we didn't do a transfusion. We just put Russ in bed, monitor and look. And then the other day we decided to, and also because we have a bed in the ICU, so we transfer him to the ICU. At this moment, we made a transfusion, 2 units of blood, because he arrived with 12, and now he is in 6.1, and we did this angio CT, and this was the result. Recent bleeding, but no active arterial bleeding. So just a little increase of the hepatic hematoma. This was February 11. His vital signs was pretty much okay. Blood pressure with no heartbeat was okay. So everything, the rest, he was good. I don't know if you want to do any other question. So we kept him in the ICU until for 5 days, 16 February 16, with no surgical treatment. We said to the ortho, you can step up, not the moment. He was clinically stable. He was accepting oral intake, and so discharged him from the ICU. And then we made a control CT. Can you pass this one, Kevin? The next one, please.
Yeah, you want me to stop sharing?
No, another one. I'm gonna send. So we did another CT. So let me go again. So we did this one. It was, I think, 14 days after the first CT. No, it's a little bit less, I think 10 days. So we still have this one. We still, here we have the liver and this huge, still pretty much this huge hematoma. But at this moment with no sign of active bleeding or anything. And here we can see a little bit better this laceration, we can say.
If only we could.
You could, but
only we could see it.
Yeah, unhappily,
Doctor,
something that I'm not. So we call the
Dr.
the
Maria,
ortho.
can I ask you a
Yes.
question? Can I
Yes.
ask you a question?
Mhm.
You had him in the ICU for 16 days, and you've done a second CT. In those 16 days, what type of evaluation did you do? Did you do any liver enzyme studies? Did you do any ultrasound? Did you do coagulation studies?
Pretty much okay.
What did you do
No.
for the 16 days?
For the 5 days you're talking, we just have the labs and monitorization, and the patient was okay. There is no, we have like liver enzymes a little bit high in the first moment, but then dropping. It was pretty much because of the trauma. So we didn't, but no other sign of liver failure or anything else. He was stable. He just had these 2 units of blood, no other needs for transfusion. The hemoglobin was stable in 9 after that. It was pretty much okay.
So unfortunately, we didn't get to see the CTs, but I am understanding that you had a very big subcapsular hematoma, and you decided not to operate. And then on the second CT, you still have a very big hematoma, but without signs of recent bleeding, and that the patient went well without surgery. Is that
exactly
the summary of the case? I have 2 questions for you, of course, Maria Fernanda, and if the colleagues, Dr. Frisby, Dr. Cassim, Dr. Utrecht, would like to answer this. My first question is, you have a very big hematoma, and you know you probably have some bile leakage also. What kind of antibiotics should this patient receive in order to prevent a secondary infection of this hematoma? Do you need to do something like this or not? My second question, I know you didn't have signs of active bleeding, but do you consider, if you have access to do so, do you consider to do angiography? And sometimes doing vascular interventional radiology, you can identify the vessel that gave orange to this hematoma. You see things like an edge, abrupt ending the vessel and things like this. And sometimes you can do a prophylactic embolization. Others say it's not worth doing this, only if you have arterial blush on the CT. So I'd like to ask the panel, what do you think about this? Let's begin with Dr. Kazim. Are you there, Dr. Kazim?
Well, first of all, I don't believe in prophylactic antibiotic in a case like this. I think you are asking for more trouble in doing prophylactic antibiotic than it is worth. Unless you know for sure that there is infection, don't do it. Second, I think this patient probably would have benefited from an angiography. It tells me that his bleeding is coming mainly from the right hepatic artery, plus or minus venous. I'm not sure about the venous part, but he may be bleeding from the right hepatic artery. And again, if you don't want to operate, which I don't recommend, and if you don't want to operate, maybe you will consider at least embolization of the right hepatic artery, hoping there will be cross communication between the right and left, and you may stop the bleed. What you're trying to do here is stop the bleed and destroy structural and functional architecture of the liver. And so far, he hasn't shown any evidence of extrahepatic accumulation of either blood or bile in the right upper quadrant or in the gutter. But again, you haven't done an FAST examination, so you really don't know where you are. I think the things that we have missed in the investigation of this patient is coming back to haunt us a little, and maybe it is because the situation is austere. Our situation doesn't allow us to do that. I think one of the things that I believe in, I don't believe in ostrich syndrome, which is just ignoring it. Thank you, Doctor.
Just for information, he didn't receive any antibiotics for prophylactic reason. I'm pretty much sure he didn't receive antibiotics at all, to be honest. And we did the angio CT at the first, as in this first or the second day. We don't have here inside my hospital, we don't have the angiography. And we talk with the radiology.
Yep.
That it's in the other hospital that we can send the patient on to see, and he said that when he saw the CT, he said there is nothing that we can do embolization from here. That's why at this moment, from 10 days that it was like he arrived at February 9, from 19, he was he manifested with this huge hematoma, subcapsular hematoma, but he after he received the blood, he was pretty much okay. No other episodes of hypotension, no need for surgical indication at this moment.
Okay, Dr. Frisbee, any different thoughts?
No, I think you pretty well covered it. His sclera is still clear, correct?
Sorry?
If the
His
patient presented
Is he jaundiced?
ictericia,
No,
Fernando.
not at all.
Okay.
well, I would
Dr.
And
Ulrich.
even it was something that it was in mind, because if he presented like with some abdominal pain or jaundice, the plan at this moment, to be honest, was like, it was written because I was already thinking that could maybe explode, that hematoma, was thinking about laparoscopy and not opening, just because of this complication. Maybe some dio inside some coliperitoneal, something like this. Not to rush in a laparotomy, but maybe try the first moment to do laparoscopy. It was also because we have the residents, we have people in training here, so this was also planned. Even the patient was pretty much okay.
So in the second CT, a big hematoma was still there.
Yeah.
And the patient got discharged home with this hematoma there.
Wait a minute. Wait a minute. You didn't let me finish.
Okay, no, I'm just very curious. It's okay. Let's
at
proceed.
this moment, at this first 10 days, the patient was okay, stable. So we just allowed him to do the surgery of the radius. So it took a little bit for he had this procedure. Unhappily, our system sometimes it's a little bit complicated. Can you pass, please, Kevin? So this was February 19. Now we are in 2nd of March. So we had a new episode of abdominal pain. So we are called, and we have another CT for him. It is still like huge, not now, a little bit more organized. It's still the same huge hematoma. So what we did at this moment is do the surgery for the ortho, and then you transfer him to the surgical team. We still like seeing the patient every day, but I just say like, fix the radial, something like you have a broken bone, do it, and then send it to me that we're gonna manage the rest. So, and then this is what we did. And so we asked for radiology to do a punction and try to evacuate this hematoma. And it took also a little bit, and they put a pigtail, 10 French, more or less drainage of 150 ml of blood. And we clean it with this pigtail, not too much, maybe 50 ml every day, and he was a little bit better.
Dr. Maria,
So
why did you decide to do something after all these days, watching him getting better and better and better, and suddenly you did a third CT, and the third CT, I don't know what it showed. Then you decided to ask the radiologist to do if he would do a percutaneous drainage. What was the reason for the decision to make the percutaneous drainage?
He was getting better, but it's still like every 3 to 4 days, like if he has a huge episode of abdominal pain. This was the reason that maybe all this distension of the glycine capsule was what causing him this abdominal pain. That's why the reason. I tried this at this moment. But I still have something coming. So can you? So I'll be back. I'm pretty much. I was pretty sure that he said to me this. I'll be back. 9 days after he was discharged, he came back with another episode of huge abdominal pain. Now he's having again nausea and not a good oral intake. and some fever that it was not inside the hospital. So we still did the another CT and blood exams. No other signs of active bleeding or infection, but he was with a clinical. He was complaining about abdominal pain that he was not feeling. Adenauer me ajuda em empachamento. I have no idea how to say this.
Me neither.
Like when you eat and you feel like full. I have no idea in English, so he was complaining that he was just having a little of the oral food and like a bariatric surgery maybe. So that's why. And then we call again radiology, the radio, if they had something different, and they contraindicated. And now it stopped. And now I'm gonna ask you guys what you are going. What's your idea now?
I'm assuming that this third or fourth CT showed again subcapsular hematoma without signs of abscess and active bleedings and things like this. But I don't have the image. So can you at least make us clear what kind of problem did you guys see on this last CT?
Let me try. We still have, now we have more now we have more plots we could see. It's a shame. Why I can't share this, Kevin? Why? If the CT is gonna be so beautiful for you to see. So we have more like this.
Is it a file that you can send to me and I can play it, or is it too large?
No, it's too large.
Meanwhile, Dr. Gustavo Fraga from Unicamp in São Paulo sent a text message saying that in his opinion, this patient needs to be open to control the bleeding. Even though Maria Fernanda said that abdominal CT showed a liver hematoma without signs of bleeding, that's what I'm understanding. And
Exactly.
the blood exams also showed no sign of infection and no active bleeding. But let's proceed with the case.
So let me try here again. I know it's a totally in good and old Portuguese gambiarra, but the impression now that we don't have active bleeding, but it changed for not a liquid. Now we have the clots. That was the point.
So it was a more organized hematoma.
Exactly.
And the radiologist thought that because it was very thick, it would not be a good option for doing a percutaneous drainage.
Exactly. So we still have this one. So we still, and now we have this, it's, I don't know if you can see, but it's a little bit bigger.
Nope.
But no sign of arterial blush?
Not at all.
And
no other was stable. He left the hospital with 10 and continues this with 10. So that's my point. And now what to do? You could not see. It's a shame. But it's still here.
Dr. Fraga, you can unmute yourself.
Yeah.
Dr. Fraga, did you want to say something, Dr. Fraga?
Yes.
No,
Okay.
I can't.
Very difficult case. I think the discussion since the beginning was a large hematoma since the first CT. There was discussion about arteriography, if it was available or not, maybe not. I think if you have a protocol for non-active treatment, liver injury, if the patient is not going well, start to have complication, the first 3, 4, 5 days, if it's not working with non-operative treatment, I understood the patient was stable all the time. But he was complaining of pain
maybe the surgeon is not a typical case for non-operative treatment because the patient looks, he has a lot of symptoms since the beginning. So in this situation, I agree with Dr. Marcelo. He wrote, I know Dr. Marcelo, he works a place with less condition, less structure. So sometimes I think you need to become surgeons and try the operative treatment for hepatic injury. It's very difficult to say this now. 1 month later, the problem is take the right decision at the moment, and understand it's a very critical case. But if the patient, the non-operative treatment, the patient is not doing well, sometimes surgery is a good option. This is my point. Thank you.
The problem is that we're gonna get in and probably we're not gonna find what is bleeding. That was the point. So that's why, like, sometimes you just need to wait. This was the option at the beginning, to wait a little, and then, okay, when the things are more stable, maybe just to evacuate the hematoma, just to do a little less aggressive than a little less aggressive than a laparotomy. And that's why we did the first one, that was the radiology, just the punction. This was because get in, open, okay. No, you cannot, maybe will not be able to find what is bleeding because it's venous. It's maybe more high or even in a posterior, so we can not having a good control, and then we're gonna put compress, and then we're gonna have maybe a major problem than I saw one. That's why. So even like we're gonna see, like I used to joke because we start to do like almost like a radioactive treatment for the hematoma, but we treat it with radiotherapy. But he was like the patient was like he was taking he was not in huge abdominal pain, and he was okay doing this, stable. Laboratory was okay, so that was the reason. So as I think we are almost about to finish.
Maria Fernanda, just
so,
Dr. Utrich was
perfect.
Yes, if I could comment, I mean, I agree with Dr. Fraga that a patient coming back this late, and you said the problem now is not bleeding, so his hemoglobin is stable, probably increasing, and he has a fever, maybe no leukocytosis and pain. So you can't do nothing, and I think the problem has evolved from one of initial bleeding to one of pain with fever. And you have to do something. So you mentioned earlier laparoscopy, and Dr. Fraga he's the king of minimally invasive or non-operative intervention. And in this case, I would, I think in spirit I agree with him, but I would try two things first. First of all, at this stage, the hematoma looks like it's organized, encapsulated, and maybe now liquefied. So I would try to repeat the percutaneous drainage. The first time 150 cc's is homeopathic. He lost 6 units of blood, all in that hematoma. And if it's liquefied, and now you get out, 2 liters or 1.5 liters of serosanguinous fluid, he'll feel much better. The fevers will go away. There's no more bleeding, and that would end the problem. Or if that doesn't work, you could consider either an extraperitoneal approach, like in the old days with a subphrenic abscess. You go in under the rib and poke through, and make it like a chest tube, but into the abscess, and you put a bigger drain. Or laparoscopy, like you mentioned earlier, that you go in there, have a look at it, open up the capsule, and then just suck out all the clot and fluid, and maybe leave it drain if you're in there. And then at the same time, if none of that worked, I agree with Dr. Fraga, do a laparotomy. But I agree with him that the principle is, at that point, he came back to the hospital. You can't send him home on, whatever. You got to be able to do something. But I think that's because the case has evolved. And I agree with you earlier, from your explanation, I would have shown that to the CT, to an angiographer, thinking, well, should he do angiography and examine all the peripheral branches of the right hepatic, see if there's a blush and can he stop it. If he said no, well, then I would have done what you did, just watch him. And but he did lose a lot of blood, and you got him this far, and I think it's sort of, at this stage, just a symptomatic treatment, which will resolve the problem. But I think you have to do something like that, something interventional to evacuate the hematoma.
Okay, Maria Fernanda, before you continue, Dr. Cassim has raised his hand. Dr. Cassim, your comments, please.
Dr. Donald Trunke was the surgeon in chief at Oregon Health Science University. He's passed away. I remember a case like this that he treated, and the patient arrived at his institution from elsewhere, and after several days like this, and he said, when a patient arrives to you, you must act like a surgeon. Dr. Fraga emphasized that quite a bit this morning. And I think this type of injury is like a volcano. It could burst anytime, it could cause problems anytime, and you must act like a surgeon. That's what you're trained for. So he would take the patient to the operating room, and he will unroof the subcapsular hematoma and take care of the bleeding, or if there is no bleeding, just evacuate everything and drain it, and take care of the patient afterward, either open surgery or interventional surgery, whatever it takes. But the lesson he taught me is don't sit on a volcano. Thank you.
Okay, nice comments. And Maria Fernanda, we have about 5, maximum 10 minutes more. Please proceed.
So the decision, as it was well said by Dr. Utrecht, so the decision was laparotomy, not laparotomy. It was a small incision, but getting open the glycine capsule, open this hematoma capsule, and get it just because what this moment I was thinking is that I need to aspirate a lot, I need to clean a lot, and maybe with laparoscopy, pneumoperitoneal, all of this, I don't want this to get detached, or I don't want to get the whole abdomen. I just want to evacuate this hematoma. Again, as I'm telling you, the patient was stable, no fever inside the hospital, no signs of infection. So what we did is just open a small incision, subcostal incision, right? More or less this 15 centimeters. We did a direct expiration of lots of clots and blood, maybe more or less this, and we clean with saline. And then there is also, we sent some material for culture, no bacterial growth. And this is what we did. And the patient after he said that he was just a small pain in the incision. Not at all. He was with no complaint. We just put a pen rose drain at this first moment. We still have a little drainage in the first 2 days, and then it was done. And then after all of this, the patient was discharged with this good clinical improvement. It was last week. As I told since the beginning, no signs of infection, and he didn't come back until now. Let's see. He was gonna return for normal consultation, but then we're gonna see how it's gonna be. But it was a good cleaning of the hematoma at this moment. But the point at this was really to get the hematoma more organized, to don't get into the bleeding moment, to having the clots. It's much more easy to evacuate and to clean than have something bleeding, and then we could not see, and then go through a laparotomy, a truly laparotomy on all of this. But he was okay at the discharge. He was better.
Okay, very interesting case. I have one specific question. I think an interesting problem when you have like visceral trauma like this one is when and how to do the prevention of venous thromboembolism. So this patient, do you have this data about this specific patient, Maria Fernanda? If he received enoxaparin or compression socks, for how long, when did it start? When is it safe to give anticoagulations for patients like this?
Then I was gonna be pretty much, I think it was in the when he got into the ICU, as he was like normal platelets. He was no coagulation, no problem with coagulation. So it was decided at the beginning, as long as he was resting bed, to put heparin and not enoxaparin. This was the decision.
Well,
We are here. We are much more pro heparin or Clexane or something like this, enoxaparin or something like this, even in no-operatory treatment, then do not do it.
and most of the hospitals nowadays, I think that they use enoxaparin. But the good thing about the old heparin is that you have a nice antidote for that if the patient starts bleeding. Protamine.
Yeah.
That's something in specific cases like this, it may be a good idea to do the common heparin. Okay, guys, I think we have reached our time limit. If anyone else wants to ask a question for Dr. Maria Fernanda, please go ahead. Otherwise, I will give her the podium again for her last remarks. But first of all, Maria Fernanda, thanks for making the effort to present. I know you had some technical problems, but obviously it's a case that gives us the opportunity to learn a lot. When to operate, when not to operate. Congratulations on the effort. Thanks.
Thank you. Thank you. And I'm sorry for this. I hope it was a shame that I could not share the screen of for the exams, because then we're gonna see what was my problem. My problem was like, and it was, I think it was Dr. Cassin said, it was a volcano. It was really like, it was like really close to really explode. And this was, so we are so slowing down.
I understand the complexity on all that, because if you can go back in time and you receive the patient with an hematoma like that, maybe the best thing would be to bet again on the non-operative treatment. Maybe, because the best thing for containing the hematoma is the capsule. But now that you can see all that happened, it makes easier to criticize not having operated before. But sometimes, if I had a patient like this, I think I would do exactly the same thing.
That's what's my point. I think more than this, it's we did an operative treatment. It was okay until what time? That's my point. It was, we have a huge one, and what I was trying to do, it's okay. I'm gonna have to get in this problem in any moment. What is the best moment?
She froze again. Are you still there, Maria Fernanda?
I think so. No, yeah, it's okay. So when it's a clot and not when it's active bleeding, was my point.
Completely agree. Sometimes it takes us 3 months to teach how to operate, 3 years to teach when to operate, and 30 years to teach when not to operate. Not operating sometimes is much harder than decided to get invasive. But, well, again, congratulations. And any other questions for Dr. Utrecht, please?
Yeah, just final comments. So, I mean, I think it's beautifully managed surgically, but I would say, giving him the heparin, maybe that's why he did bleed during the first week. He went from from 12 to 9 to 8, all the way down to 6 while he was on the heparin. So, and it's impossible to know. And the option is, well, there are other prophylactic measures, the stockings plus compression boots, or a young guy like this, getting him up out of bed, and if he's otherwise healthy. So, and, when he went to orthopedic surgery, the orthopedists love to anticoagulate the hip patients. I don't know about the wrist, but, especially if this was the orthopedist that saw him initially, I might have, made him aware about the hematoma, be careful about anticoagulation. But, you can't say that the anticoagulation had anything to do with how much he bled. He did well in the end, but I really think it's beautifully managed surgically, because initially operating, it wouldn't have been for the same purpose. You may have stirred up more bleeding. The hematoma wasn't organized, and then 12 or 14 days, whatever, then it was ripe, and you were operating for a complication that occurred at that time, and it was a much smaller operation rather than big laparotomy, and and he would have taken longer to recover from the earlier laparotomy than he did from the small, limited extra peritoneal drainage. So I think it's beautiful management and the appropriate restraint, and using a more pinpoint approach. So I really applaud you for that. About the the heparin, it's you had to do something. If he had had a big pulmonary embolus and you didn't heparinize, you did something else, that would be worse anyway. So, even if he did cause some bleeding, it's probably you had to accept that possibility.
Fantastic. So, Maria Fernanda, we need to disconnect your final remarks.
Thank you to everybody, and sorry.
Don't worry.
Don't sweat
I
the
put the
small.
chat. I put the CME information in the chat earlier for those who are interested. Thank you,
And
Dr.
Thank
Adnar.
you.
Okay,
I'd like
before we
to.
go,
Yes.
before we go, can we hear from Dr. Fraga? He's the man of wisdom. I'd like to hear from him before we close.
I think
Before Dr. Fraga speaks, I will just say that Maria Fernanda will be in the Brazilian Trauma Congress in October in her city, Porto Alegre. So I would like to invite you all to go to this Congress and discuss very interesting cases with us. Nice to be here. Dr. Fraga, if you have any final comments.
Excellent. Congratulations, Dr. Maria Fernanda. Beautiful case. But I think you learn a lot with this case. Maybe for the next time you can think about a surgery before. This, my opinion, because you had a similar case like yours some months ago, and the conclusion of our meeting was that you need to operate more if you have a failure of non-operative treatment. I think this case was a failure of non-operative treatment. But excellent case. Congratulations.
Adenauer, you still there?
Yes, I'm here, and
To
my
tell you
best
the
regards
truth,
to you all.
yeah, to tell you the truth, the best thing that you could teach today to your medical students is just exactly what you said. It takes a long time to know when not to operate.
Right.
That's it.
Yeah.
Bye, guys.
See ya.